Welcome, everyone, to the Child Safety Learning Collaborative, supporting states across the phases of improvement. This is a Children's Safety Network webinar. Next slide, please. The Children's Safety Network is supported by the Health Resources and Services Administration of the U.S. Department of Health and Human Services under the Child and Adolescent Injury and Violence Prevention Resource Center Cooperative Agreement. And I just want to emphasize that the information or content or any conclusions today should not be construed as the official position or policy of HRSA, HHS, or the U.S. government. Next slide, please. I'm going to hand this over to Caitlin to take us through a few technical tips.
Great. Hi, everyone. Welcome. I have a few technical tips for you today. First, the quality of your audio depends on the speed of your internet connection. If the audio is choppy, please find a more stable internet connection or listen over the phone by dialing one of the phone numbers found in the Zoom invitation. All participants are muted, but you can submit your questions throughout the event using the chat, and we'll address those questions in the discussion portion of our webinar later on. For captions, please click the caption button at the bottom of your screen. Sometimes this is within the More icon, which is 3 dots at the bottom of your screen to turn on automatic captions. And we will be sharing our resources, recording, and slides within the next 2 weeks posted on our website for you to access as well. Jenny, back over to you.
Thank you, Caitlin. Next slide, please. I am Jenny Stern-Carasone, and I'm the Associate Director of the Children's Safety Network and the lead of the Child Safety Learning Collaborative Motor Vehicle Traffic Safety topic team. And I will be co-moderating our event today with my colleague, Maria Cotratis, who serves as the lead for our CSLC Suicide and Self-Harm Prevention topic team, as well as our CSLC Data Manager. We are going to provide some overview on the design of the CSLC and then turn over the microphone to representatives from each of our current topic teams who are going to share about their current work. Next slide, please. The Children's Safety Network was established through funding through the Health Resource Service Administration's Maternal and Child Health Bureau in 1990, and CSN serves as the primary vehicle for the Maternal and Child Health Bureau, providing technical assistance to Title V agencies on injury and violence prevention. Today, we're going to share highlights from one facet of our comprehensive work, the Child Safety Learning Collaborative, which you've heard me refer to as the CSLC. Next. The CSLC's vision is to actuate the Children's Safety Network mission by providing targeted technical assistance to Title V agencies in order to effectively advance injury prevention strategies and reduce child and adolescent injuries, hospitalizations, and fatalities nationwide. Next. Learning collaboratives are commonly described as a systematic approach to process improvement where participants will share experiences to accelerate learning and broaden implementation of best practices. What we refer to is all teach, all learn. The design of our CSLC is for states to create strategy teams to address an injury topic or more than one that they choose to work on. And then the Learning Collaborative convenes those state strategy teams into topic teams. And then we use quality improvement methods to build on shared aims, evidence-based approaches, data analysis, and targeted technical assistance in order to accelerate the implementation and spread of effective strategies. The goal is for states to be able to employ public health approach and close the gap between research and practice and support evidence-based practices to reduce child injury and violence and demonstrate significant change over a 5-year period. Next. To achieve this vision, we utilize the Children's Safety Network frame for quality improvement and innovation in child safety. This framework draws on elements of the CDC social ecological model, the Foundation Strategy Group's collective impact approach, the Institute for Healthcare Improvement Breakthrough Series, and the Associates in Process Improvements Model for Improvement. The focus of our framework is to support states in order to make improvements and innovations in their child safety systems and develop their child safety workforce, which we then believe will lead to positive health impact in the populations that we serve. The framework enables states to effectively use data to understand their target populations and identify which areas they want to focus on, as well as to build public will and state jurisdiction capacity in key areas essential to achieving sustainable and scalable child safety results. We target the following core tenets of the framework in order to do this: the identification and use of data-driven, evidence-based, and evidence-informed strategies and programs in order to enhance child safety expertise, increased effectiveness of management and leadership, and systems improvement through ongoing commitment to shared learning and principles drawn from the advancement in improvement and implementation sciences. Next. Building off this framework, we know that these three cornerstones that I just described are essential to success. We offer resources and support in all of these areas, and our technical assistance is tailored to the needs presented by each individual state strategy team, as well as the topic team as a whole, and the Learning Collaborative as an entire group. This can mean that we're designing webinars to meet emerging needs with experts from the field. We're seeking out and implementing innovative approaches, new research, or emerging practices. It also can mean that we're designing tools to assist states in developing and sustaining effective partnerships or providing training and tools to help Title V agencies establish an improvement portfolio that integrates with overarching state objectives and is building a culture of change. Next. As noted in the description of the CSM framework, one approach that we leverage is the model for improvement. This is a tool for accelerating organizational improvement centered on the clarifying an aim, or what are we trying to accomplish? And then the next step in this process is to determine changes that teams think will result in an improvement and decide what data they're going to collect and how to analyze it so they can determine if the change is actually an improvement and not just a change in circumstances. We utilize Plan Do Study Act cycles, PDSAs, as a primary tool to conduct small tests of change in order to effectively try out new child safety approaches and interventions throughout the system and adapt them in order to ensure that they are really working in the various contexts before implementing them system-wide. Next. The focus of the work in the collaborative, therefore, is to identify areas that are ripe for improvement, to support the states and jurisdictions developing a knowledge management system that supports innovation and sustainability, the ability to use real-time data to inform decision-making and rapid improvements, and ultimately to enable the states and jurisdictions to implement and spread evidence-driven strategies and programs in order to reduce childhood deaths and injuries. We use evidence-driven strategies and programs that are aligned with the injury-related maternal and child health national performance measures and also meet the following criteria. These are strategies that have the potential to close a significant gap between current prevailing practice and the best scientific knowledge in injury and violence prevention, that they show a strong potential to contribute to the reduction of injury deaths, hospitalizations, and emergency department visits amongst infants, children, and adolescents, and that they have demonstrated feasibility and potential for breakthrough improvement by at least some states and jurisdictions. And those are then compiled into a change package, which is one of the primary tools that we use in the Learning Collaborative. Next. The quality improvement process is intended to build from the ground up by having teams determine their need and then establish who's going to be on the team, the partnerships and relationships that they will have in order to best serve and address that need. Then form SMART aims and select the change ideas and measures that will enable them to reach that aim. Much of the day-to-day work is then identifying data sources and establishing processes to collect and use the data, setting target goals and short-term 90-day aims that allow conducting small tests of change, those PDSA cycles, and then have more frequent assessment of the progress in order to determine what works so that then they can start expanding the work towards implementation and eventual spread system-wide. I'm going to now hand this over to Maria to share more about our current CSLC work.
Thanks so much, Jenny. So the Learning Collaborative consists of 3 cohorts that are running over 3 years, and each cohort is approximately 18 months. We're currently rounding out our first cohort of this 5-year period. Between cohorts, as many of you who are on this webinar may know, there's the application period reopens, and all states and jurisdictions are encouraged to either continue in the collaborative or join the cohort for the first time. And they also have the option of adding additional topics or even switching topics if their needs have already been met. So in cohort 1, our 4 priority topics were bullying prevention, motor vehicle traffic safety, and that includes child passenger safety and teen driver safety, suicide and self-harm prevention, and sudden unexpected infant death prevention. We chose these topics by analyzing data trends in maternal and child health national performance measures and identified these injury topics that had the most significant injury rates, but also have the greatest potential for progress. So teams were asked to participate in either 1 or 2 of our topic areas in the first cohort, and are, like I said earlier, are able to add additional topic areas in any of the successive cohorts that we have. So in cohort 1, we had this lovely spread of states across our country, and we're really happy to be with you today to share a little bit more about what they've done. So as Jenny shared, we have small tests of change. And for those of you who are not familiar with our Plan, Do, Study, Act cycles, we really want to start off with thinking about what will happen if we try something different. We identify objectives, we review data, and make sure that we create a plan to carry out the cycle. Who will be responsible for it? What will they do? Where will they do it? When? And of course, we have to plan for data collection so that we can collect some information and analyze it later on in the cycle. So we'll carry out the plan, we'll document any problems or unexpected observations, and begin data analysis to really compare the data to those original predictions in the plan part of the cycle, and to summarize what was learned. And finally, we want to think about what's next. What changes are to be made? Should we adapt, adopt, or abandon that change that we just tested? If we will make an adaptation, maybe we'll be going into the next cycle of a Plan, Do, Study, Act cycle. So this is our primary tool to really study what we're doing and to document any of the changes that are being made. So I would love to introduce to you, if you're familiar with it, these are the phases of improvement in trying to implement and spread a change. So we start off in the develop phase of improvement, where we're developing a theory and prediction. We move on to test, where we test our change in a variety of conditions and collect information about that, collect some data, both qualitative and quantitative. We'll move into implement, where we make that change a part of our routine operations, and then move on to spread, where we're sustaining and spreading to other locations. So I would love to take some time to describe each of these strategies, each of these phases a little bit more. So when we are developing a strategy, we're really it really involves the preparation for altering the work or the activity and how this is done. We really want to focus around who, what, when, where, and what is and how it is needed. And in a PDSA cycle for developing a strategy, we could focus on developing the relationships among the agencies, developing buy-in and commitment to the work, planning for data collection, preparing activities prior to testing a strategy. So as we'll hear later on from our panel, this could involve developing capacity, really firming up our partnerships and the relationships that we're going to focus on. When we want to test a strategy, we'll make sure that once it's developed that we can test it and refine it. So we really want to make sure that this is a small scale trial of this new approach or new process that we're trying, perhaps hopefully in the CSLC, you've selected this approach from our change package. And the test is designed to learn if the strategy results in the improvement that you're hoping, and to fine tune the change to fit the organization and the people it serves. So we're really looking at these small scale trials, and that we are testing it under a wide variety of conditions. We know, for example, that something that might work in DC may not work in the suburbs of DC, in Maryland, or in Virginia. Something that might work in a rural population might not work very well in a very urban population. So we also want to see that if an unpredicted result is obtained, not to view it as a failure. The success of the strategy is to learn whether the strategy resulted in that improvement. So we'll continue carrying out those tests, and we really want to document in our PDSA cycles what has been done, and any changes that we could potentially make as we're continuing to test the strategy. To implement a strategy, really the goal of implementing a strategy is to make it a permanent part of your organization. So once you've tested, you've documented all of your adaptations, you know that that the strategy is resulting in the improvement that you're hoping to achieve. And you've tested it under a wide variety of conditions. That's when you move on to implementation. So implementing the strategy often requires the creation of support systems, policies, procedures, trainings, new job descriptions, really making that part of the everyday practice and the routine practice of your work. And finally, when we want to spread a strategy, this is the intentional and systematic expansion of the number and the type of people or units or organizations that are using the strategy. We want to make sure that the communication that the strategy addresses that the strategy exists, that the strategy addresses an existing problem, and evidence of the advantage of the use of the strategy over the status quo facilitates sustainable adoption of the strategy. So we really want to focus on that communication, on making sure that everyone knows that you have tested it, you have implemented it, that you've gone through this process, you've learned about your communities, you've learned about what works, and that now you are making this an intentional and systematic expansion. So one of the tools that we have in the CSLC is this phases of improvement decision tree. And this is just a small snippet of it. So we want to make sure that we are following along the teams and that we're really meeting the states where they're at. So we start off with some questions, and if you answer no, as the first question indicates, you would be in the develop phase of improvement. And if you answer yes, depending on those answers, you would continue on to see if you're in test, implement, or spread. So I would love to introduce our panelists and the examples from the Child Safety Learning Collaborative. So Rose Thomas is here from Ohio. She is a public health consultant for the Bureau of Maternal, Child, and Family Health at the Ohio Department of Public Health. And Rose will be speaking about the work Ohio has done on sudden unexpected infant death prevention in Cohort 1. And the Ohio team is in the develop phase of improvement. So welcome, Rose.
Thank you so much for the introduction, Maria. Like she said, I am with the Ohio Department of Health, and we worked on the sudden unexpected infant death prevention project, and we partnered with our child fatality review coordinator, our epidemiologists, researchers, and our Safe Sleep program team. One of the frameworks that we worked with was Plan, Do, Study, Act, and just to really see what do we want to accomplish with the work that we're doing with the other Safe Sleep team. And so we kind of looked into current Safe Sleep programs within Ohio, and also looking into those social conditions that shape safe sleep barriers for parents and caregivers. So when we first started, we had an in-person CSLC kickoff. And so we kind of learned a lot more about the different frameworks that we can use, news and dived into all those different topics and activities. And I loved it because I was able to learn a lot more from other states who either did this program already or doing a new program, and then learning more about how their programs are structured, and just gave us a lot of great insight when we were able to work with them. So we did have a lot of shifts as we started this project, a lot of department and agency shift, but ultimately we were able to kind of work through building an interagency survey to identify gaps and opportunities for safe sleep education across Ohio. So we just wanted to kind of get an idea of what that would be like so we can structure maybe an in-person training event for providers across Ohio. So we don't initially assess that information. And so as we started working together and we started to plan a little bit, we thought it would be great to get that insight on what's really happening on the ground. So we wanted to look into kind of what are those broader experiences. So not just looking at medical providers, but for other providers like doulas, WIC staff, community health workers, and seeing how are they providing those culturally relevant safe sleep education and barriers. And so we went back and forth and trying to see how can we reach that audience? How can we reach those people on the ground working with parents and caregivers? And what we did was we again used the Plan, Do, Study Act and looked at different areas in our Ohio Equity Initiative counties. Those are counties in Ohio that have higher prevalence rates of SUID, and we looked into federally qualified health centers, teaching hospitals, local health departments, children's hospitals, and a lot of it was just trying to figure out how are we going to tailor our outreach to the people in the community. How are we going to share this information on our survey? So we kind of just went back and forth, and our cohort calls were really great because we were able to share this information with people across the country who are also working on SUID prevention, and just kind of seeing and just troubleshooting what those different ideas are. But I can't give enough praises for the people we worked with, like Claire Grace and Maria, who helped us through that survey. And just kind of understanding how we can measure the different questions and tailor it to the people that we're trying to reach. So that's a little bit about what we've been working on so far. We still are kind of in the development stage too, trying to still put out that survey and seeing who we can reach. So thank you.
Great. Thank you so much, Rose. It's lovely to hear about, excuse me. It's lovely to hear about the work that you're all doing. And I'm sorry, you're going to see me cheesing a lot because I'm really proud of all of the work that has been done in the CSLC and over the years, and I'm particularly proud of this group of panelists. So I'm sorry if you keep seeing me cheesing. So next, I would love to introduce Marissa Rodriguez, who is a child safety group manager at the Texas Department of State Health Services. Marissa will be speaking about the work Texas has done in child passenger safety as part of the motor vehicle traffic safety team in Cohort 1. And the Texas team is in the test phase of improvement.
Thanks, Maria. So we have, I guess it's a little difficult for us to kind of narrow it down, but for this, we are doing, during the testing phase, which is where we decided, because the size of Texas and because our agency is so large, I think we were really looking and trying to nail down, like, where do we go? And so we opted to take a step back and really trying to look at the data. And because there's a lot of great work happening in Texas, however, a lot of it is very siloed. And so we felt it important to kind of step back and see how are we looking at the data, what data can we collect, what's available. And so we thought it would be a good idea to kind of also relook at an interagency survey for us because we're a large agency, and so our agency is kind of split within child passenger safety on how we're funded. And with that separation also creates different ways of collecting information, reporting information, and how the programs are run across the agency. So with this survey, we were hoping, we actually did learn a lot and sent out a survey to all the programs that are offering services in the various communities across the state. And so through those surveys, we were able to find how it was so different, how people were collecting information, reporting information, and it was very different between the two programs. And so part of our goal is to look at that data in a similar fashion so that we can best report not only for you all, but for our communities and for our funders. So it kind of created a unified approach to kind of looking at the data. So that's kind of where we started. It seems like a small piece for us because there's so much great work happening. But in order for us to be able to look at that data, it's important so that we can move forward into our next steps. So, and just to kind of give you an idea, the two programs, for example, our Safe Riders program is funded differently. So we have over 66 partner agencies and over 110 sites distributing seats across the board. And that doesn't include on the other side. So it's just a lot. And so it was really important for us to look at that data. And it was also helpful getting assistance in TA from the CSLC because you guys helped us frame our questions in the way that is helpful for the data we needed to collect. And so without your help, we wouldn't have been able to do what we did. But it was really helpful, and we're appreciative of that. I guess some of the things we are hoping to do next is now that we're maybe implementing on more of a national level on how to use the National Digital Checklist form potentially to start collecting the data that way and really promoting it within our agencies and partners. So, and we've started doing that already. So we're hoping that we can just expand on that in the next cohort. In addition to some other things we're hoping to do. Like I mentioned, we have so many partners that are willing and wanting to join our efforts, and we want to let them in. And I think there's so much more work to do. That's just kind of, we started there kind of small but large, and look forward to partnering with a lot of people moving forward. So.
Great. Thank you so much, Marissa. Next, we'll introduce two folks from Massachusetts. Jane Ayers is the Youth Violence Prevention Coordinator, Education Specialist, and Bullying Prevention Project Lead at the Massachusetts Department of Public Health. Mary Kate Sullivan is the Assistant Director of Program Elementary at Friends of the Children in Boston, and they will be speaking about the work that Massachusetts has done in bullying prevention across a number of our cohorts. The Massachusetts team is currently in the implement phase of improvement. So welcome, Jane and Mary Kate.
Thank you, Maria. The Massachusetts Department of Public Health's Child and Youth Violence Prevention Unit works in partnership with the Department of Education to maintain a comprehensive bullying prevention initiative. We recognize the pivotal role of public health in collaborating with regulatory agencies to enforce the law and the importance of community youth organizations and fostering a sense of belonging and school connectedness for young people who are affected by bullying. Before joining the Child Safety Learning Collaborative, we had questions about the process involved in implementing effective safety measures. Through our participation, we discovered that the Pennsylvania State Health Department had partnered with curriculum writers and trainers to develop a version of the OVEUS Bullying Prevention School-Based Program specifically for community youth organizations. We then piggybacked from what they were doing and worked with OVEUS to create an online training program, ensuring it aligned with a request for proposals designed for 52 diverse youth organizations with varying needs. This process took 2 years prior to launching the training series. We now have 14 sites across Massachusetts. My colleague, Mary Kate Sullivan, will talk about the work at one of the sites.
Thanks, Jane. As she said, I'm Mary Kate Sullivan. I work at Friends of the Children Boston. For those who aren't familiar with Friends, we partner with Boston Public Schools in high poverty areas to seek out youth who face the highest barriers. And these youth are then matched with a one-to-one paid professional mentor from kindergarten until they graduate from high school, working with them for about 12 to 16 hours per month, with their families, with the youth, basically any system that they come in contact with, we would support them with. So Jane fortunately connected me with the Alveus Bullying Prevention Program last winter, and I became certified in bullying prevention, and have been able to integrate some of the learnings from that training into our organization here. So one of the biggest ways that this training I've been able to integrate is that all staff at Friends of the Children is required to now take a bullying prevention training. We thought that it should extend beyond just mentors, because the staff here, everybody interacts with the kids. So we wanted to make sure everybody had an awareness of what bullying prevention could look like and how to intervene if necessary. And any new staff that come in going forward will be required to take this training as well. We also conducted a survey on our youth to assess whether or not bullying was happening in our space. Fortunately, given our unique model, there isn't really a space where kids are here without an adult present, unlike an after-school program or like a school hallway. Because of the adults being present, we found that it wasn't really an issue, but we still wanted to make sure that our inclination was correct and give voice to the youth if they felt that it was happening here. I think one of the biggest takeaways from the training was that we collaboratively as a staff created a set of community agreements, as well as developed some restorative justice practices in case these agreements weren't met. And every youth and adult that comes into our space are required to read through them, sign off that they agree to it. We just got it blown up on a poster in our space. So that was one of the biggest takeaways. And finally, we've incorporated more get to know you activities with the youth. The idea being that the more that they feel connected to each other and find things in common with each other, the least likely they would end up in a bullying situation. So we've had a lot of great success so far. Looking forward to seeing how this continues in our work here.
Wonderful. Thank you both so much. And finally, I would like to also introduce LaDonna Merville. LaDonna is a communication specialist and grant specialist at the Tennessee Department of Health Suicide Prevention Program. And LaDonna will be speaking about the work Tennessee has done in the suicide and self-harm prevention team across a number of cohorts. The Tennessee team is in the spread phase of improvement. So welcome, LaDonna.
Thank you so much, Maria, and thank you all the other great presenters. So today I want to talk a little bit about what we've done with our implementation of Sources of Strength program. The Tennessee Tennessee Suicide Program is funded with a grant from the CDC for comprehensive suicide prevention. And we have a partner in that organization called the Tennessee Suicide Prevention Network, and they have been working with us to implement an upstream suicide prevention program called Sources of Strength in our middle and high schools, community faith-based organizations, particularly in rural areas of Tennessee. In this effort, which we started back in probably 2022, we did it because we saw that through our data that between 2019 and 2023, Tennessee was experiencing a 47% increase in youth suicide rates among youth aged 10 to 17. So with our contracted partner, we were in the process of trying to recruit schools and faith-based organizations, community-based organizations to participate in the SOS program. However, we were struggling with getting traction and getting implementation, particularly, I think, because most of the outreach we were doing was to large statewide gatherings of educators and other health educator-related folks. And we really weren't seeing a lot of uptake on the program. So we decided to utilize some of the tools from the Child Safety Learning Collaborative to pivot to more focused approach. We used a more targeted and data approach, informed approach to increase our reach and impact. The first thing we did is we worked with using the theory of change so that we could connect youth mental health needs with our Sources of Strength program as an evidence-based solution. So we then created some specific aim, a specific aim statement that said that by August the 31st of 2025, we would provide suicide prevention and social emotional education to 6th to 12th graders in 15 rural schools, faith-based organizations, or community-based organizations. We really wanted to have a very measurable goal so that we could come back and make sure that we are accomplishing what we wanted to accomplish. To do that, we participated in the structured 90-day AIM cycle, learning cycles, starting in February of 2024 through March of this year. So in each of those cycles, we implemented some small-scale testing of our implementation strategies, looking at how our outreach approaches were using to see if we were actually being successful in connecting with the schools or organizations and getting folks trained to implement the program. We also measured how many sites that we were engaging, how many youth we reached, and whether or not the program was being implemented correctly. So I'm excited to say that as of today, we've learned that we have reached our goal. We have 15 sites underway in Tennessee that are implementing Sources of Strength. 8 are secondary schools, 2 faith-based organizations, and a community organization, and I think a couple more schools in 6 counties, 6 rural counties. We are involved with 144 youth, giving them some suicide prevention and social emotional education using peer-led campaigns, staff training, and student engagement activities. And just from that standpoint, we feel like using the tools that the Child Safety Learning Collaborative offers helped us with that implementation, and we'll continue to use those as we continue the spread of the program.
Wonderful. Thank you so much, LaDonna. And I appreciate all of you sharing a little bit about our program. And I'm going to stop sharing my screen now so that we can go into a panel discussion. I know that we've had a couple of questions come into us in our chat. So lovely to have you all on. If we could, oh, great. We're spotlighting all of our panelists. Wonderful. All right. So thank you so much for sharing all of that information about each of your programs. You've all done an amazing job. And like I said, I can't stop cheesing because I'm really proud of all of the work that you've done. So we know that your efforts are to reduce injury across your states, and that many of you have been addressing these key priority injury topics for much longer than you've been in the CSLC. So can you share a little bit more specifically about how the CSLC changed how you're doing your work? And this could go to anyone.
Well, I'm happy to talk about that. I think particularly using the AIM, the 90-day cycles to study and refine what we were doing, we were able to look to see what was working, what wasn't working. We found again that the outreach, broad outreach was not working well for us, and we decided to refine our outreach and identify some better recruitment strategies. For example, we found that most schools don't want to implement things in the spring. They want to wait till the fall when the semester, the new school year begins. However, some of the other organizations, like a faith-based organization, which we thought might be wanting to start at any time of the year, they also wanted to start in the fall because they kind of follow the school year too with their programs with their youth. So it's really learning what your audience needs and wants, and then adapting your program. So the 90-day AIM cycles gave us that opportunity to do that refinement in our program.
Wonderful. That's a great example, Adana. Thank you so much for sharing. Anyone else?
Maria, this is Marissa.
Mm-hmm.
I think it allowed us in particular to really focus our work, because sometimes if we can just create more work for ourselves, and it seems like you're just kind of running in circles. And so aligning what we're doing for the CSLC and kind of trying to make sure everything aligned, the information we're collecting, the data. So it's not only for you, it's actually helpful. So thinking through those goals and measures up front and really trying to figure out what are we able to do now, and kind of set goals, what we can collect, then what we can move into later. I mean, it kind of created a vision for us by having to do that. And it's not, I won't say forced us to do that. However, it was great because it created accountability for us, really looking at the goals and setting ourselves up to succeed. So I think it forced us to kind of look at it in that way, and it was very helpful. And not doing that, I feel like we wouldn't have probably done as much as we did, because everybody's busy, and so it kind of helped us align and move forward a lot easier, I would say.
Great. I appreciate the note about like really systematizing the process, and that it may feel like there's more work, but in reality, you're actually able to do more with what you're working on because you have a process behind it. Jane, did you have anything to add?
I was going to mention that the Plan, Do, Study, Act cycle has really helped our work. From public health lens, a lot of times when you oversee contracts, it's more of compliance, and making that huge shift and having that language with the vendors and the grantees that they are the consumer, and what we're going to do is just make a plan, and then after we make the plan, really look at like what barriers that we may encounter, and just having that open dialogue has really created trust amongst the sites, and it has also opened our understanding and really looking at completing the cycle, the Plan, Do, Study, Act, and that it's continuous. So once we finish and we really look at what we're doing, we're able to start the cycle over again.
Great, thank you. And thank you for the reminder that the Plan, Do, Study, Act cycle doesn't end on Act. It can continue into cycle 2 and beyond. Wonderful. So it sounds like you've all shared a little bit about the challenges of your work, and I'm wondering if you've had any challenges specifically in applying the CSLC approach to your work. Marissa mentioned about how it may be in the beginning, it feels like a little bit extra, but that it helps systematize the process. Jane has mentioned a little bit more about really changing the way folks think about implementing a new program. So I'm wondering if you had any other challenges in applying the approach to your work.
From
Maria,
Massachusetts, oh, I'm sorry. I'm going to be really quick. For Massachusetts, what it really helped is break down the silos, because we're so used to working, your funding is bullying prevention or violence prevention. And with us, for us, at least my programs, it's even a specific age range. And so that's where we focus in schools. But being able to take on this approach, what we're able to do is work in partnership with other programs across bureaus, so that now we're all using the Plan, Do, Study, Act cycle. And we're finding out that the clinicians in my program work in the school-based health center, and the school-based health center staff are working with the same youth that we're working with. So that has just really strengthened our ability to have a collective impact.
Wonderful. And Marissa?
Mine was going to be along the same lines of collaboration. I think collaboration can be difficult sometimes if you're across different agencies or different partners. So being coordinated and intentional can be hard sometimes, but important.
Great. Since you both mentioned some partnerships, and I know LaDonna also mentioned partnerships, Rose mentioned partnerships, you all mentioned partnerships. So I'm curious about what innovative strategies or maybe even non-traditional partnerships you've developed since joining the CSLC, and how has that informed your work?
I can start. So not necessarily non-traditional partnerships, but trying to utilize the folks that we're already working with. I think it just helped me kind of like think about a little bit of who is within our bureau, who is our like current partners already, and I just thinking about, okay, maybe I could reach out to the reproductive health section that I've already been working with and see what kind of partners they have, who can we reach out to that they already work with already. So I think for us specifically, when we did have our own partners with like hospitals, we also tried to think about what other partnerships could we leverage within our section and also within like other areas and different programs that we have, because we do have such a big section as well.
And this it's kind of along the same line, but a good reminder. Just today, one of the folks in my team, Terry Love, mentioned the fact that he was meeting with a high school principal about a different program that the Department of Health is doing, but he mentioned our program, the Sources of Strength program, and the principal was very interested. So taking that kind of approach that, you know, maybe it's not your program, but you can at least plant the seed and say, if you're interested, I can provide you with the contact person to give you more information. So, you know, as we participate in our programs, looking at ways that we can engage others and really give them more bang for their buck, if you want to call it that.
And similar to what everybody has already said, one of the things that we've been really intentional about is looking at the youth at our funded agencies as our partners. And we're so used to talking with the staff who are amazing, but then asking the staff to have the youth look at this and see what's missing. And then we learned so much about what adults need to know, how youth respond to bullying. And it just has really now shifted our culture, because now we're trying, even though all of us are adults, we're trying to be able to have a culture where we can be able to collaborate and work closely with youth. And what does that mean for a state health department?
Wonderful. That's such a great reminder. You know, we're serving youth, we're creating programs for youth, but we need to know how everything is affecting them and how they're also receiving the information and what more they need to support. So Jenny, I see that you've joined us. So welcome to our conversation here.
Thank you.
So I am, yep, go ahead.
Oh, I just wanted to pop in because, you know, I wanted to encourage folks that are joining us today, that if they have questions, to please post them in the chat so that we can share them with the panelists. And in listening to you all and just, you know, the amazing variety of work and how this, you know, process has helped to expand your awareness of who's already in the room that you can work with or who's not yet in the room, and engaging them to, you know, develop new perspectives, strengthen your partnerships. You know, something else that we've talked quite a bit about is the role of data and how, you know, that's an important factor in quality improvement to really inform your work. And LaDonna, you talked about the, you know, how utilizing the 90-day aim is such an important resource for you, because it's helped to winnow things down into more small, you know, kind of bite-sized pieces. I was just curious for others about how you're using data and recognizing that, for example, Rose, you know, you're in the develop phase. And so at this point, you're not seeing outcome data. There may be a lot more qualitative data that's informing your work. And I was just wondering if folks could share a little bit about how you're using data and how maybe that's changed as a result of being in the CSLC.
I
So,
can go ahead.
Oh, well, we've done this again. No, it's your turn first. I went
Well,
first
I
last
was
time.
just, no, I was just going to mention um, in being able to use the national digital checklist form, we'll be able to really look at misuse and like child safety seat misuse and more detailed variables in the data, which we don't do now. So right now we have not very, Texas is doesn't use it, the NDCF too much. So we really have no good picture of what that looks like statewide. So I guess I would say it's important for us to be able to collect that and have a better picture. And that's kind of one of our goals for child passenger safety.
So for the Department of Public Health, our partnership is with the Department of Education. So we rely on a lot of their data. They have data on school culture and how they really look at an indicator or at least a concern for bullying is school attendance. And so being able to have these partnerships with schools, and here it is the after school youth organization programs like the Friends, of how they work very closely with schools and how staff actually have conversations with the staff at the school with the after school program, which I'm sure Mary Kay can talk more about. And they are the frontline folks that will know, well, a young person might be showing up at our program, but they are not really showing up at school. And then that is a way in which we can really strengthen the loop. So it's using the data, using Department of Education's data, and then being able to tie that into the program design to keep the community youth organizations connected with schools. And Mary Kate, if you want to share, please feel free.
Sure. Yeah, we definitely use attendance. Every month, mentors are expected to collect the attendance data for each of their kids. And so for kids who do have a significant amount of absences, the mentor would be working not only with the youth to get a better understanding of what the barriers are, but would have conversations with caregivers, with school staff to see what some of those barriers are, and try to find support to navigate some of those barriers. Because like Jane said, it's such a powerful indicator that it's definitely something that if they do have chronic either tardies or absentees, then definitely something we like to address.
Outstanding. That's really informative. I see that Lisa Fontaine Torres raised her hand. And Lisa, if you have a question, if you'll post it in the chat, we don't have the ability to unmute today. So we'd love to share your question with the panelists. And I just really want to acknowledge that, that Marissa, you said that you're all very busy, and that is very true. And that, being part of the CSLC is not something that you're receiving any additional funding for. Its intention is to align with the work and the goals that states already have in maternal and child health and injury prevention. And, I just really want to appreciate the work that you're doing, and then how you're engaging in the CSLC to contribute to the entirety of the CSLC's impact. I am not seeing any other questions in the chat. And so I think I'm going to move us towards clothing and closing, not clothing. And again, I really want to just, I'm cheesing a bit too. I've learned a new term. Oh, there is. Joanne Miles Holmes from New Hampshire has asked about whether or not any of you have started using PDSA cycles in other projects that are not CSLC. That's a great question, Joanne.
We actually launched a 6-part training series on using PDSAs to launch culturally and linguistically appropriate services. So our class initiative is grounded in that, and it's one training that all of the grantees watch and continue to watch because we videotaped it.
Super. PDSAs, I think, are one of the hurdles that can take some time to, figure out how to work into it. But I know working with the Texas team that you all are really, utilizing the concept of the PDSA to break down your work and look at each of the components. And so sometimes, we don't even realize that we're doing PDSAs because they're so natural in our process. Where you try something, it didn't quite work, you're going to change it, or maybe it didn't work at all, and you say, forget that, I'm not going to try that again. I think that's a big piece of being in the CSLC is that reiteration of, remember, it's breaking things down into small tests of change. Well, thank you all so very much. I'm going to have Maria bring up the slides so we can conclude. As noted at the beginning of our presentation today, we are currently launching Cohort 2 of our CSLC 5-year project, and we do still have application opportunities for limited topics: motor vehicle traffic safety, suicide self-harm prevention, and drowning prevention are all open for more applicants to join. And we'll continue taking applications through the end of this month for that, to get people onboarded and to launch with our first CSLC activity in June. So please reach out to us, and there's more information you can access on our website here. Next slide. Thank you again for joining us here at the Children's Safety Network. We do appreciate your feedback, which helps to inform and improve our work. So please do take a moment to complete the short evaluation, and we look forward to having you here for future events. All of our archives are posted on our website, so you will get a notification of the recording for this event, but you can also access past events as well as learn about new events on our website. And if you are not yet a member of our newsletter, I strongly encourage you to join to stay apprised of all of the activities going on at Children's Safety Network. Thank you, Maria, and thank you to all of our panelists. Goodbye.